Oh, what's up, Charles? What's up,
Hey,
Charles?
brother.
Look like you're on the
Can you hear
road
me?
again. Yeah, I can hear you. Can you hear me?
Yeah, I can hear you good.
Okay, perfect, perfect. Oh, what is that? Oh, that's your hand. Oh my God, I thought it was an octopus. I thought it was an octopus, man. I really thought it was an octopus. What's up, Charles? I know you're coming back
Whew.
from Hilo, Hawaii.
Yep, yep. So I
Glad you
figured
could
I
join
can do it.
us.
It's had a little snafu at the handoff from Hilo to Honolulu to Kauai. So the day started out very early, and but I'd like to extend a great big mahalo to the fine people of the town of Hilo, the employees at Hilo Airport. Did a fantastic job. Really good personnel up there. And I just wanted to say mahalo. And ate at this new for lunch had a new Japanese restaurant in town. I think it's called Sakura's. I've never been there before, but excellent food. So I just had a unagi donburi for lunch, and that's pretty good, pretty darn good, pretty darn.
Awesome. Well, welcome back home. Glad you make it back safe.
Yeah, thank
Uh,
you.
and drive safe going home. Don't get distracted by the show. We got Dr. Jemel Grayson. I think it's Grayson or Grayson. We'll find out when he comes on from Australia tonight, guys. It is Thursday, 4 p.m. over there. So he'll be joining us at 7 o'clock our time. Looking forward to that discussion. We've had Dr. Jerome Kim share with us from South Korea, but we're going to hear from Dr. Jamal or Jamel about Australia. And we hear a lot of stuff about Australia, about lockdowns and all that. We're gonna find out from him firsthand what's really going on in Australia and and get his insights. We met on Clubhouse. I heard him speak a very little bit, but really enjoyed what he had to say, and asked him to be on the show, and he obliged. So he's on tonight, and I'm hoping that you folks will get some value out of tonight's show. What's up, Dad? My pops is on in Seattle. Um, my stepmom had to go back in the hospital. She's back in the hospital again. Yeah, it's
Oh,
yeah. So it's just one of those things. Village, if you can shoot off a prayer tonight for my stepmom again, and to my dad and to the whole family, because no one wants to hear loved ones. And I understand, Charlie. I understand that the world is trying to get us to believe that it's time to relax and I have no idea what Dr. Jamel will say tonight, but that's one of the questions will be posed. But I also want to learn what they're doing in Australia that's different as it relates to testing, quarantine, isolation, therapeutics, how they're treating their patients.
hmm.
Um, so yeah, I'm looking for some really good information. But getting back to COVID, 12 people today, people. 12 people died in the state. 12 deaths. So again, I'm going to share a slide when the doctor comes on about the positivity rates, because I've been preaching this for quite a while now, that we shouldn't be only focused on case counts. And it sounds like the doctor has, yes, he has. Oh my gosh, he's in the green room. He can hear us, but we cannot hear him.
Well, let me say
So
something first.
like he's
Let me say
peekaboo.
something
He's got
first,
a
Mel. Let me
sure.
say this.
Yes, sir.
There's a lot of people. We
Go ahead.
talked about
Go ahead.
this. Can you hear me? Okay. A lot of people said that this virus is like a flu. Okay, okay. There's a whole group of them that say this, but think of it this way. Okay, say it is a flu, right? Just say it is a flu. How many of you out there want to get this flu over and over again in a short period of time? Because right now, the flu, we have flu seasons, right? It comes, then there's a lengthy period of time that there's no flu. Now, if they're calling COVID a flu, then you ask yourself, this thing comes back so rapidly. How many of you want to catch that flu over and over and over and over again if you think that's the flu. How many of you want to go through that? I know I don't. So
Well,
just keep
and
that
let
in
me
mind.
ask, and
Yeah.
that's a great point, Charlie. And let me ask you this question, and let me ask the
Yeah.
viewers this question: how many people that you know, friends, family, close friends, relatives, whatever, that you know have died from the flu personally?
Mm.
I don't want to hear anecdotal crap. I want to know how many of you know some loved one, family member that has died from the flu. Well, let me tell you
Mm.
this. KITV called me, did an interview with me the other day regarding our high positivity rate here in Hawaii and why our positivity rate is the highest in the state. And she asked me how many people that I knew or that close friends or family that had died. And at the time, as I did my quick trying to stimulate my memory cells, eight, Charlie. And I'm not counting your brother. I'm not counting your brother because I really didn't know him, but I felt like I did through you. So that would be nine. But eight, Charlie, a
Yep.
first cousin, right? A first cousin, uh,
Hmm.
a dear friend, a mom and a daughter, 1 week apart because of COVID. So I don't like when people talk about this is like the flu. This is just like a cold. This is so uh, mild. Don't worry. Our own lieutenant governor keeps pounding it in our head. Oh, it's don't worry, guys. Don't worry. No, we worry. And I'm going to ask the good doctor tonight about his thoughts, and I'm going to share the slide of our positivity rate. Again, we're unscripted, we're unrehearsed. I don't know what the doc is going to say. I'm looking forward to it. So I think let's bring him in because I'm excited as heck. I am
Yeah.
excited as heck. And look, he's
Okay.
wearing a suit. Charlie, he's wearing a freaking suit.
Always a professional.
Hey, Doc, I'm Mel. The Hawaiian driving his car is Charlie. We're Mel and Charlie. We do this 3 nights a week. We've been doing this since March of 2020. It's going on 3 years. We've had guests from all over the world. We are blessed to have you on. I did, prior to bringing you on, explain how we met through Clubhouse. Heard
Yeah,
you speak a little bit, but it seemed to me like your knowledge was quite vast. So, why don't you go ahead and introduce yourself to our viewers, and we'll get started, my friend.
yeah. Hi, everyone. My name is Dr. Jemel Grayson. I'm a medical professional, healthcare provider. I am currently here live from Victoria, the state of Victoria in Australia, and I've been a part of the COVID discussion since the beginning, helping educating people on the importance of vaccines, talking about COVID in general, how the virus attacks your body, how does your immune system react to it, and also, I've been a vocal educator on long COVID or post COVID syndrome, as it's called. It is a set of it's a set of symptoms that occur after a COVID infection. It is incredible. I think it's incredibly important in a public health emergency that we have sort of a standardized care plan and a public health policy to address long COVID. Um, yeah,
Awesome, awesome. We have put a quite a large focus, Charlie and I, on long COVID. We've had long COVID patients on our show. We had one last week that, in fact, it affected her brain, in addition to other things, but it affected her brain to a point where the neurons in her brain were dying, and she's going through some brain therapy right now, electrical, whatever. I'm not going to try, but anyway, and she is getting better, but she's far from full recovery. One of the big issues you heard us talking about the flu is many of our leaders here in Hawaii don't address the long haul. They look at the vaccination rate, they look at the recovery rate, but in that recovery rate, in the people that are considered recovered, by some experts that have come on our show, the estimate 40 to 50% of them have some pretty severe long haul symptoms, and that's quite alarming. But before we get there, Doc, if you don't mind, you're in Victoria, Australia. Can you share with us the landscape, the COVID landscape right now, of where you're at, or in Australia in general?
yeah, sure. So in Victoria, this in the state of Victoria. I think initially they had they had a zero COVID strategy, not just in Victoria. I think in all of Australia they had a zero COVID strategy, where and they were trying to bring down transmission itself and the introduction of the virus. But I've always been very skeptic about that protocol, mainly because zero COVID strategy would be highly doubtful, because in an ever evolving pandemic where the virus is mutating at a rate that we don't usually see except for the flu virus, it is incredibly um, uh, just in terms of public health, it could be incredibly detrimental to follow that. And I think the government realized it, and they were going for all of the other mitigation factors, mask wearing, vaccine mandates, and all of the other strategies. But I think right now, with Omicron cases coming down, I think today it was announced by the Victorian Premier that they're going to bring down the restrictions in Victoria, and they're getting rid of QR codes, which usually people have to check in when they go into different places, and they're also removing some of the restrictions they had for entertainment venues and different settings. But I think historically in the pandemic, Australia has really stood out because they've been able to successfully avoid, except for several instances, and avoid huge health strain on the healthcare resources that they have here. But I think it'll be different in the future, in the coming days, because they're going to open up the international borders, and they're going to have they're lifting restrictions. I think it's more on the political side of the spectrum, where I think forces that require the economy of the state to come up. I think that plays a role in lifting of restriction, but I think that's where we are at the current moment. They don't currently have a strategy for long COVID. They recognize it, but they don't currently have a standardized care plan for long COVID as well. In terms of numbers, we have seen case numbers fall, hospitalizations and death, including fall. But it's like I keep saying again and again, we are in a relay race. All right, this is we're taking lap after lap. The race is not over. We're just in the middle of another lap, and it might be it might be too early for any country in the world to open up and ease all restrictions, mainly because of the very evolving nature of the current peak with Omicron. We see different scenarios happening in South Africa, in the UK, in Canada, and in the United States, and the trajectory that it takes has been very different. So I think for us to be able to understand how Omicron is gonna go ahead in the future, we have to be very cautiously optimistic. Even though case numbers are falling, that's good news. We have to still be cautiously optimistic.
Hey Doc,
Yeah,
this
it
is
seems.
Charlie. Oh,
Oh,
yeah,
Mhm.
I wanted to
Yeah.
ask the doctor how important, it seems like those countries where discipline is really practiced, it's practiced really hard, discipline, those numbers seem to come down. Do you agree with that?
Oh well, this is very multifactorial. Like no one thing is contributing to the rise in fall of cases. I mean, epidemiology itself is a very has been incredibly challenging for us to figure out what's causing the fall, what's causing the rise, and it's also making us very hard to predict future slides. Future trajectory of this virus. Well, I would like to on that question, I would also like to answer one of the main political ideology behind lifting of restrictions, especially with regards to Omicron, is that they believe that it's a very mild virus. I mean, there is a lot of scientific evidence to suggest that it is a milder version of a milder variant. But just to look at the virology behind it. Um, I mean, we've seen several variants of concern over the last couple. Throughout the pandemic, mostly they oscillate between transmission advantage and immune evasiveness, right? Uh, Variants that have considerable transmission advantage usually always spread faster and dominate. You had your alpha variant and you had your delta. Delta also had significant immune evasiveness, which proved that it was everywhere and causing it. It is still the most severe form of the variant we know. And then you had the other variants, beta and gamma, and those variants had immune evasiveness, but without transmission advantage, they really didn't stand a chance. So you might not have heard of them because they didn't cross international boundaries as much as the other two did. But and this brings us to Omicron, right? Omicron, and in fact, at the start of the show, you were mentioning that a lot of people call it equivalent to a flu. Um, I wouldn't go that far. We have there are several papers that have been published which talk. I mean, there is a significant difference between how the previous variants had functioned and Omicron. We see that in Omicron, there's a different entry pathway. Previous variants used TMPSS2, which is kind of like which is a protease enzyme, which basically means cuts proteins and stuff. Uh, the reason why is that with that and the advanced transmission, it helped the tropism of the virus, the way in which it attacks the human body, was different, right? Like from Delta, which uses an endocytosis pathway, endosomal cytosis pathway, which usually is different. The difference between them is that the one that uses TMPSS2 pathway has a more cell to cell transmission. That means it's able to penetrate deeper lung tissue. So it was able to cause more severe disease in terms of clinical scenario. But you had Omicron with the other pathway. It's not as associated with increased cell to cell transmission. So there was a lot of replication on lung surface, but it didn't actually penetrate the parenchyma as much, which is why one of the reasons, along with another reason, which is it doesn't antagonize our cell signaling, interferon gamma. So it's usually how our cells communicate that we are infected with the virus, so come and kill us. So the Omicron is not as good as Delta in antagonizing that chemokine. So for these two reasons, we thought. I mean, the research still stands. I mean, we can see it in data, epidemiological data. That Omicron does seem milder compared to the most severe form of the variant we have. But the problem with that is that when you have a virus that has such high transmission rates, I mean, it more than makes up for the less severity uh, with having high transmission rates. So it's going to reach more people, and it's going to find vulnerable people and people who haven't been vaccinated, and it's gonna do its job there. So we have to still be careful and when we lift up all of our restrictions, we bring together a situation with high transmission, and basically we let Omicron into everyone, and it's going to find vulnerable people to infect. So I mean I mean, just because of that, you can know that Omicron is, even though on paper and in data it looks milder, this is on a public health level, on a larger view. I mean, there are still individual vulnerable people who will still be just as susceptible to Omicron as they are to any other variant. So we have to be very careful about just opening everything up and letting us have high transmission. In fact, in the U.S., 98% of the geographical data says that there is high transmission, almost all in 98% of the U.S. So we're not looking at the end here. This is not the end.
Thank you, Doc. I mean, I think that's what we've been trying to say. We've had multiple experts that really echo your sentiments almost to the T. And I think majority, in fact, I don't know of any medical expert that's relying on the science and relying on or focusing on public health It's the political decisions that are being made that's creating the problem. Now here in Hawaii, we're surrounded by ocean. We can actually one of our leading experts in the state actually said, we were the envy of many other states in the country because we had the opportunity to stop variants from coming in simply by implementing a testing or quarantine program before. We chose not to. We in fact lessened or reduced the restrictions for travel, so anyone that had a vaccination card could come right in without a test. Anyone that didn't have a vaccine card had to test 72 hours before they got on a plane. Um, and they never stopped that. And in fact, Delta made its way in, Omicron made its way in, and wreaked havoc. We lost a lot of people uh, during Delta and Omicron. My concern is, and I've been saying this for a few weeks now, is the positivity rate. That's a concern. Yeah, because we're focusing on numbers, but in America right now, especially in Hawaii, majority of our people are testing at home with a home test. It doesn't get recorded, so it doesn't get to the Department of Health. So it doesn't show up on our daily case counts. These people are testing positive, asymptomatic or mild symptoms. They call the doctor. Doctor says, "Hey, isolate, quarantine yourself." But none of that data gets to the Department of Health. But I want to share a slide real quick, and I just wanted to get your insights. This is today's updated as of today. And I don't know if you can see that, but we're in Kauai, so we are the fourth dot. As you can see, it's a very dark red. The bullet is dark red, which is extremely high risk. The others
Mm.
are red, which means high risk, but our positivity rate on our little island of about 75,000 people is 15.7%. It was 18% last week. Honolulu, which is the largest island, over 1 million people there, we're more than twice the amount as far as positivity rate. What are your thoughts on positivity rates versus case counts?
This brings me back to really what I wanted to emphasize in this. If we're getting anything out, it is going to be the incredible significant difference that boosters are making to our current that we're currently our current fight with Omicron, right? Um, we know that boosters work, and we can see this in data, especially, I mean, we're talking about test positivity rate. We're seeing that with Omicron. Even if you've had previous non-Omicron infection, and you've had 2 doses of the vaccination, with previous non-Omicron infection, we see almost 15.4 to fourfold decrease in efficacy of the in antibody response, right? So we have a falling antibody neutralizing antibody response. And with if you think you've had Delta before, so you should be fine with Omicron, it's just mild. Well, the if you have had previous infection, that also falls, I mean, as I said, 15.4 to 4.4 fold, than than your in antibody were at the end of your infection. So why do we need boosters at this point? Boosters are extremely important at this juncture, because there is an incredible amount of study, not just one or two. There's an incredible amount of studies which show a significant rise in neutralizing antibodies. Um, with a third booster shot. I mean, I'm not talking about immunocompromised patients, patients with low immunity. That is specifically, the CDC came out and said, like, they would probably need a fourth booster because we don't see as much as of an increase in antibody response, right? So why did I bring up boosters? Because CDC also released a data which says that if you have had the booster, if you're a U.S. adult and you've had a booster, your likelihood of testing positive goes down by four times. And that is an incredible. Now, I'm not talking about hospitalization or death. I'm talking about your likelihood to test positive, and also your likelihood to be hospitalized or have severe disease decreases by 95%. Let me just quickly. Yeah, 97. I'm sorry. It's 97%. It goes down. So boosters are critically important to our current fight against Omicron, and we're gonna we're probably going to get to this later. With regards to long COVID, what we're seeing more and more often is that patients who have had mild or asymptomatic disease, which it would probably be the case in Kauai, um, where you'll have a set of people who will test positive but will not require hospitalization or ICU admission, but would still remain at significant risk because there's new evidence suggesting that even if you've had milder or like asymptomatic variant of the disease, you're still at increased risk for cardiovascular outcomes, poor cardiovascular outcomes. So what am I talking about? I'm talking about a decreased ejection fraction, exacerbation of heart failure, arrhythmias. We're talking about thromboembolic disease, blood clots in your body. So across the spectrum, people are getting different cardiac comorbid, and these people have never had, not all of them, but we see that the fact that a lot of them didn't have any pre-existing condition or cardiac comorbidity had nothing to do with the fact that they developed. So what does that mean? Healthy citizens who test positive for COVID and did not have any form of symptomatic disease can still be at higher risk of having a poor cardiac outcome. And when you do that at a public health level, at a public or state health level, you're looking at numbers that's going to significantly strain resources, especially in a small state like Hawaii. The cardiac care, how much cardiac care can be provided to the citizen when that outcome starts manifesting itself. So, I mean, that's very important considering that there is a high positivity rate there. There is a long-term effect to high positivity rate, and I don't think a lot of both state and federal government are considering this possibility. I know there is a lot of people pushing for more responsible decision making, but at the same time, it's already happening now, right? And it's the same thing with just talking about national health level. A lot of countries a lot of states like New York and mainly the Northeast state where I worked are currently their cases are coming down. But if you see other countries like Alaska and some southeastern states, you still have cases climbing up. So this one and that could happen on a county level too, like it's happening in Kauai. So one size fits all easing of restriction is definitely worse than just easing restrictions in different parts. And a lot of attention need to be paid to make responsible decision making here. And this is not just me, this is evidence talking.
We know for a fact it's not just you, Doc. And again, we didn't speak or anything. I had no idea how you were gonna be responding to the questions, but yeah, you're, like I said earlier, all of the experts that have come on this show, are beating the same drum. It's unfortunate our leaders and policymakers are not listening, and it's they have the duty to create a balance between the economy and health, but they are talking about lifting all travel restrictions. So no tests, no check for vaccination cards in March. We get about 30,000 visitors a day come into our state from all over the world. Majority comes from other states in our country, but we do have a lot of international travelers coming from hot spots. They will be able to get on a plane without any test, without any proof of vaccine, and come right in. And I cannot for the life of me understand how our leaders think that's going to be safe. As we know, right, we've been through enough surges that we know how quick this can turn on us. Delta ravaged our state. Where I live on Kauai, we have 9 ICU beds. We have 75,000 residents. We probably have about 15,000 visitors a day on any given day, but we have 9 ICU beds. Oahu is the go-to city or the county. So we send our stroke patients, our serious cardiac patients, we medevac them to Oahu. But when Honolulu is peaking in the hospitals, which they are, yeah, maybe not from COVID patients, but the fact of the matter is the hospitals are are serve all ailments and injuries from car accidents and so forth. So our concern here, as I think is the case with many places, is the capacity of our healthcare systems, and that I fear that once we open up the it's not very restrictive here right now. I mean, you can go to a restaurant on Kauai, you can walk right in. You don't have to show a card. You don't have to show a test. It is, I don't know why people keep saying we're on lockdown. We're not even at that point. But once the borders are free and open, I'm very afraid that we're going to see so much more virus come in, and that our delicate healthcare system will not be able to handle it. Um,
Exactly. I think the strategy is going to be a booster plus strategy. So we know that the booster itself, they cause significant B cell expansion and increase the amount of neutralizing antibody. But it's not to say that vaccines are the primary boost vaccines we got are completely useless. There is a study that recently came out that talks about how there is a preserved cellular immunity. Now we're not talking about antibody immunity, just cellular, but CD4 plus and CD8 plus cells, there is a significant preservation. Almost 80 to 84% of those T cell responses are preserved to Omicron. So even if you were vaccinated before, that really helps. But when you take the boosters, what you have is that when you have one weapon, which is cellular immunity, but also your neutralizing antibodies, they're brought up to standards. Like it comes back up, and you have the best protection possible. And we've just discussed, even if you have had natural infection, you still need to get the booster because, if you haven't had an infection from non-Omicron variant, you still have a seriously decreased amount of immune response to Omicron. And also, I mean, I know that the powers that be in politics, even if they can continue to decide to open Hawaii, there are practical steps that we can take, right? So first of all, booster is the number one point, but also you can wear masks. N95 masks have clearly shown that they're effective in stopping transmission. So they can't continue to wear your mask, even though it's more for others. And also there is an acronym that I want to say. It's called DVT. So DVT is basically distance, maintain social distancing, make sure there's proper ventilation. It is a respiratory virus, so make sure there's proper ventilation wherever you go to. And the T is time. You need to decrease the amount of time you would spend in a very compromising situation, like a closed doors, no ventilated area. If you're going shopping, decrease the amount of time you actually have to be there. And if you can ensure other factors, make sure the place is properly ventilated and that you're socially distancing and you're wearing a proper mask. So masks and DVT, these are mitigation strategies that are proven to decrease transmission. So your likelihood of testing positive. See, I just quoted the CDC data that says if you're a booster, you're 4 times less likely to test positive. And if you're 4 times less likely to test positive, you're 4 times less likely to get long-term poor cardiac outcomes. So that's going to be very important over the coming days if your government does decide to open up, all of the restrictions. I think that's going to be very crucial.
yeah, and I think we're hearing that from so many people, but yet it seems like here in America, anyway, in the U.S., more and more states are talking about lifting the mask mandates completely. Our governor has made it very clear that he's not going to do that, which is thank God. But our lieutenant governor is pushing to get that lifted. Thank God it's not our lieutenant governor's choice; it's the decision of the governor. So there's a little bit of conflict there. But one of our viewers is asking, Doc, I want to put this back up again, this thing, and she's asking, she's from Oahu, which is Honolulu, and she's
Mm-hmm.
looking at the 7.2 positivity rate.
Mm-hmm.
If you pick any one of these, how significant? What's the significance of the positivity rate in COVID?
Well, I mean, as I mentioned before, the significance of testing. I mean, we know that vaccines, although they help reduce transmission, they do not stop you from transmitting and getting infected in the first place, right? But there is a study out of Israel that says that if you are vaccinated, and you do get infected by COVID-19, your chances of getting long COVID or post-COVID syndrome decreases significantly. I think it was like 50%, and that's really important. I think that's what people get wrong by, by considering it a flu, because even if you're not hospitalized, but you test positive, that is your positive test rate. For number one, that means transmission is high. All right, that's what a high positive test rate means. The transmission is high. Plus, there's always reporting artifact. I've always had a problem with reporting because the way these things work at the state and the federal level, and plus how the tests are given. There's always there will always going to be some reporting artifact. But even if we even while talking about test positive rate, first, that means like the transmission rate is high. Omicron has a very high R0 number, so the transmission rate is high. Number two is that it also means that if you've once been infected and you're not vaccinated, and you don't get and you're even if you're vaccinated, your long-term cardiac outcome is going to be very different. And the reason why I keep saying cardiac outcome is because cardiac cancer and cardiac diseases are some of the worst killers in the US, except for now where COVID is taking over. It's almost I think every 37 seconds someone dies from COVID. I mean, that is it's still going on. People fail to understand that hospitalization right now, I mean, at the peak of Omicron was more than there was at the peak of Delta, and even currently, it's not fallen below the peaks of Delta, and this is not the end of the race. This is another lapse. We're still running, and it's just coming back to the question with there's high level of community transmission in that area. So you need to be able to protect yourself by various mitigation factors. Make sure you limit the amount of time. Make sure the area is properly ventilated and you socially distance. But also, we're looking at a possible public health outcome that is going to be very negative uh, in 6 months to 1 year down the line.
Yeah, I definitely want to save some time, Doc. I did want you to share a lot about the long haul COVID and the impacts, because again, we're so short sighted, right? We're rushing to get out of this COVID pandemic. Everybody's anxious to get to endemic status, but what they're not realizing, our Senate president just popped on. Thank you, Senator Kochi, for coming on. Appreciate you coming on. Um, what we are not looking at is exactly what you just talked about. Where are we going to be 6 months from now, a year from now, 18 months from now, with these long haul COVID patients? So let's save that for the last discussion. One thing I really want to ask you is, as far as Australia goes, and I know Scotty Shapiro is on tonight. Um, Therapeutics, treatments, how different are? I mean, I know you were doing some work in New York, so it sounds like you're very familiar with how our country is performing. But in Australia, I get COVID, I get admitted to the hospital. If I test positive, what therapeutics do you have, and how are you treating your patients up in Australia?
Okay, so first of all, the therapeutic indications of all of the therapy that we have are very limited. I mean, I'm going to address both America and Australia. Therapeutic indications, we have antivirals, we have monoclonal antibodies, but the therapeutic indications for these medications are very limited. So first you have Paxlovid, which is an oral antiviral, which is given within the first 5 days. You have to get it within the first 5 days, or it's pretty much useless. It does show 85% decrease and severe progress to severe disease, but we have there's the public healthcare here is very robust, and the Medicare program is very robust as well, but in terms of therapeutic, the window is very narrow, right? You have to even so if you don't have a Paxlovid, then you can give monoclonal antibodies. There's sort of belimumab, and I think they're belimumab. So your monoclonal antibodies are given, but also, so with Paxlovid, you need to know if the patient has significant kidney issues, or you need to know if there is any drug-to-drug interactions, and if there aren't, if that cannot be given given, then you go to monoclonal antibodies in that order. And if monoclonal antibodies aren't available, then you go to IV remdesivir, 200 gram. I'm sorry. It's an IV form and it's given, but all of these, mostly antiviral and monoclonal antibodies, they have a very limited therapeutic use. It means you have to get it within the first 5 days. I think most of those years there's still healthcare disparity where patients cannot access healthcare in that particular time. What happens is that it does go into that window where no medication is going to be that useful, and we do have dexamethasone and a steroid drug that can really help with severe disease, but still there's very limited therapeutics that are available right now. I make no mistakes, vaccines and boosters remain a very significant part of preventative medicine that go into controlling the virus, because the medications we currently have are very limited in nature on when we can use it and how we can use it.
Okay, so it is in Australia. It's the same as here in America, where it's limited monoclonal antibodies. So it's not different in Australia.
No, it's just on a global scale, right? There is just no therapeutics for COVID-19 that are not that are outside of that critical window.
And that 5 day window for Paxlovid, I mean, it's that's difficult because I may have been infected and have very minor symptoms. By the time I get to the doctor, it's beyond the 5 day period. Will Paxlovid even work at that stage? I
Yeah,
hear that 5 day window is very critical for that specific drug.
and then with monoclonal antibodies, I'm glad CDC finally came to their senses and dropped the 90-day requirement, because before it used to be, if you've had monoclonal antibodies treatment, you had to wait 90 days to get a shot, like a vaccine shot. And I've never thought, just but mechanistically, I never thought there was any replication competent issues there. So I just figured like they should, and now they've dropped it to 10 days. Once you're out of isolation, you can have your shot. So that really makes sense to me now. So but all of these treatments are very limited in nature, as I just mentioned. So yeah, we need to follow mitigation factors and vaccines and boosters. So that's where the most of the fight lies.
Okay, real quick question. I'm just looking at the viewer questions and drug interactions with Paxlovid. Is there? Go ahead.
Drug-to-drug interaction is usually how Paxlovid interacts with other drugs that you might be currently taking that might either decrease its efficacy. So that's something we look at once we have your chart. It's like, oh, these are the medication he's taking. If none of them interact with Paxlovid, then we can go ahead with it. If there's significant interactions, then we'll probably move on to monoclonals or remdesivir, which usually doesn't have any interactions.
Yeah, I had heard, I'd seen, I don't know if this is true, but statins is one of the drugs that would conflict with Paxlovid. Are you aware of that?
Yes, of course. So, there is an enzyme in the liver that is usually complicated in most of these drug-to-drug interaction, P450. So usually when a drug is there all of the drugs are removed by our liver. So when one of the drugs, either incapacitate or make more of it. So what happens is that it's occupied with, taking care of this medication, and so it either brings it down the level of the drug, or it brings it up. So that's your drug-to-drug interaction. Either it decreases efficacy or makes there's more of that drug in your blood. So certain like statins and omeprazole, some drugs like that have certain effect on that P450 system, and some other drugs have the opposite way. And then you have commonly implicated drugs that are like warfarin, and these drugs are commonly implicated in that metabolism. So that's a decision for your for the physician who's treating you,
Right.
for him to make. And also, I would like to say that everything I say here is for education. If you need medical advice, you need to speak to your physician.
Yeah,
Yeah,
yeah. We usually put that disclaimer out there. I forgot to do that, but yeah. I mean, I do actually in my comments. I get a lot of personal questions that I do not ask because that it's
yeah.
not fair for you, and it's definitely not healthy for our viewer who should be talking to their doctors. So I apologize
Yeah.
if I'm not asking questions. It's
No, no, no.
because
It's just a
if it's
disclaimer
general,
that.
if it's general in nature about the drug or yeah, fine. I did want to ask one more question, and this has nothing to do with medication or whatever.
Mm.
uh, in America, the CDC dropped the quarantine or the isolation time from 10 days to 5 days. I'm sure you're aware of that. What are your
Mm.
thoughts on that? I mean, there was a lot of us felt that was premature, that it, I can honestly say, based on personal experience, not me personally, but family members, that one sibling got COVID, the spouse didn't contract the virus until day 7. So I'm just curious what your thoughts on are the 10 days to 5 days.
I mean, it was when it first came out, I had an issue with it because there was not enough evidence to, I mean, to really recommend it. And I understand why they did it. I have a friend who sits on the FDA advisory committee, and we do talk, and I understand, but there is, um, just like the lifting of restrictions on the states, and that was very premature because there is still the transmission dynamics of Omicron is still unknown to us. We know it spreads fast, but it's we still there's still a lot of things we do not know about COVID-19, especially the Omicron variant. So we need to be very cautiously optimistic before just go ahead with everything. Just unlocking everything and slashing like quarantine times. It's a mixed bucket for most, but I generally didn't agree with it. I didn't see any evidence for it. And even with the latest FDA, I'm glad FDA came to their senses in regards to vaccinating below 5-year-old kids. I mean, they had I think it was like they had a 2-dose regimen. I think it's 3 milligram, and they the data when the data finally came out, we found that there was not it didn't have much of immunogenicity. There was not enough neutralizing antibodies. So they decided to go for a three dose regimen for kids, and they thought, well, we can give a UA for a 2-dose regimen, and then they will be primed for a third dose. And I thought that was such a bad idea. And they finally came to their senses, and they said, they're not going to go through that. They're going to wait for more data on the third dose before they make a decision on that. And that's a good decision, because we were expecting there to be vaccination for below 5-year-old children who do make up a significant percentage. So, but I'm glad they came to their senses. But so just goes out to show that sometimes some things could be premature, and but I hope they reverse that decision and make sure there's enough time for healthcare staff to make sure that they are safe, in terms of their own health. That's what I was.
Yeah, thank you. It was it was like, okay, we're going through this pandemic, and the surge is hasn't ended. We're still climbing, and we're going to reduce the time for people that are close contacts or actually who contracted the virus. I thought was kind of foolish. But again, you know, in government politics, in America, I'm sure you're probably aware that the airlines industry had that major crash. Remember, there was like 2,000 flights canceled because
Mm,
crew members were sick. They couldn't
mm,
get to the airport. So the airline industry made a plea to the CDC, says, "Hey, can you at least lower it down to 5 days so we can get our people back to work?" And they did. And
yeah.
I think that was a very, very bad decision. And I believe it. It caused a lot of people to get sick and even die.
Mm,
All right. Long haul, Doc. I did want to spend some time on long haul because of your depth of knowledge, and we really, again, appreciate you coming on tonight, all the way from Australia. Um, we're not we're not looking down the road. We, meaning our leaders, policymakers, decision makers. It's almost like desensitizing the numbers of deaths. We on our little island last week, 5 people died. That's a lot for our little island, but it's just 5 people died. Long haul, not even talked about in our state. as far as the medical and political communities. It's on shows like this, it's in Clubhouse that we are hearing from long haul survivors. Why is that, Doc? Why are we not giving long haul the attention that it deserves?
Beats me. I mean, it beats me because I've always, I mean, we have had patients who advocate for themselves. We don't have significant education on this issue. Even physicians are not aware of it to some degree. But if you look at long COVID, it's a serious issue. I mean, we have so what we currently know about long COVID is that there's two types of long post-COVID syndrome that we see. It's in people who've been hospitalized first. I mean, this is gonna draw a very a close line between post ICU syndrome that we were ringing our bells about before because we thought it was a public health disaster waiting to happen, and what we see with hospitalized patients is that people who have significant systemic inflammatory response syndrome, that is like a lot of inflammatory response in your body, they subsequently get what's called a compensatory anti-inflammatory response syndrome. It's when there is a significant immune suppression. It usually works well, but when patients who have been hospitalized with COVID-19 were followed up, I mean, the data suggests that evidence suggests that there is a chemokine called transforming growth factor beta, which is a pro-fibrogenic and anti-inflammatory particle. I mean, chemokine that. So basically, what it does is that heals things, right? It decreases inflammation and heals things. Sounds good, but in this catabolism, it's part of a catabolism syndrome. What it does is that causes fibrosis all over in different organs, and then what you have is what you see in patients who've been hospitalized is severe lung fibrosis, and we also see cardiac dysfunction, and even so, to an extent there could be fibrosis in brain and different sort of neurological neurons. I mean, we do see this is the most severe form of post-COVID syndrome that we see, and currently we're trying out immunomodulators. They're still under study. We don't know how useful they're going to be, but that is one type of syndrome we see in hospitalized patients who develop post-COVID syndrome. That is here, and they're different from interstitial lung disease. I mean, this is still pulmonary fibrosis, but doesn't look like interstitial lung disease. So. We have cardiac dysfunction, exacerbation of heart failure. We have cardiac fibrosis, a lot of cardiac dysfunction, not just, and then your kidneys. It's just any organ you can think of. I mean, this chemokine is implicated in causing fibrosis and a severe form of that disease, right? But this is the same thing that happens in post-ICU or post-sepsis syndrome that we were talking about early before the pandemic, saying this is a public health emergency. Now it's a part of this post-COVID syndrome as well. Now, with patients who have not been hospitalized, who have had only mild COVID symptoms, they also have post-COVID syndromes because the receptor that COVID-19 uses, the ACE2 receptor, is so ubiquitous in our body. It's everywhere. The symptoms that these patients experience are significantly different as well. From brain fog to arthritis to mild cardiac dysfunction. You have neurological impairments, tasting problems, smelling problems. So, I mean, there's just a wide variety of these symptoms that we see in patients who have not been hospitalized. These are either had mild symptoms and the most common one is extreme fatigue. We see this with some other post-viral syndromes, but more so with COVID. I mean, we have clinical data. I mean, the brain fog that you were talking about before, that one of your guests talked about. I mean, we have clinical data now that the brain of a person who have had brain fog due to COVID looks significantly similar to someone on what we call a cancer brain. Let me explain this a little bit for the benefit of your viewers. What we see in animal studies, and this is very early, but we do the clinical data does correlate, is that when we look at the brains of animals which have been infected with the COVID-19 virus, just in their lung, all right, just in their lungs. So that means the virus didn't travel. We see significant elevation of chemokines, the inflammatory chemokines, in the brain of these mice, and we take and when we take data from people who have long COVID, and especially people with brain fog. I mean, people with long COVID also have that inflammatory chemokines, but people with brain fog have specifically a chemokine called CCL11, or eotaxin 1, which is a chemokine that is implicated, with um, in all of these patients. We see increased microglial activity in sub white matters, in subcortical white matter in these patients, right? So we see literally areas of their brain, like for example the hippocampus. Usually neurogenesis in hippocampus helps with memory, and we see patients with long COVID who have had brain fog have significantly less neuroblasts, which means the kind of like a kid neuron. So we see significantly less neuroblasts in these patients than normal people. So we know that there is a direct relationship between, it's not just in people's head, like you would call it. There is clinical data that suggests that this happens, and not just this, they also have less oligodendrocytes. So the direct effect of that is that these people have less of a neural circuit function, and directly implicated in decreasing axon health. And it's we can see this in clinical data, so it's not in people's head. There's a significant effect, and all of these patients have had mild disease, so they were not hospitalized. These are mild patients with mild disease, and so there is clinical data that supports that because of COVID, because even a mild infection, since mild is a word thrown around often, even with a mild infection, you can end up with a cognitive deterioration that can really debilitate you. And that's what we see in patients who come up with brain fog and extreme fatigue, is that their brain literally changes. Their brain literally changes, and we can see the comparable to what we call a cancer brain, neuropathobiology. It's very comparable to a cancer brain. So it's incredibly important for us to understand that the consequences of even a mild COVID infection can be, even though you might not know someone, at a public health level, it is dangerous because, like I said, when we were talking about in Clubhouse, more than 30% of people who have had, during the Delta wave, reported having long-term symptoms of COVID. So, and mainly women and young adults were the ones who were implicated with those symptoms. So you're opening up most of these states with no mask mandate, no mitigation protocols, no mass testing, and with booster coverage, especially in the US below 50%, you're opening up doors for public health, like healthcare infrastructure to crumble, because people are going to have serious cognitive deterioration, worse cardiac outcomes, and just worse general health overall. So when they finally get a grip on this control, when they get the economy going, you'll have a majority of a workforce suffering from debilitating long-term effects of COVID and won't be able to take part in the economy. So you're basically shooting yourself in the leg, because you open it up for the economy, but the huge number of workforce are going to get seriously affected by long-term symptoms of COVID. So and this is not just anecdotal evidence. This is in clinical data. We see it in clinical data of the neuropathobiological changes in the brains of patients. We also see in large study, we see that there is a significant worse cardiac outcome, even if you just test positive, and the grade increases. So if you're hospitalized, you have way worse cardiac outcomes. Your risk of having worse cardiac outcomes raises significantly. So this is what we've always been saying. It's not just about serious death and illness. There is another component to the pandemic that is very hidden from the political eye, and this is gonna I mean, this is going to be a public health crisis at some point. So, I mean, it's incredibly important to let for the medical fraternity to let establishments know that this is going on.
Yeah, unfortunately for us in the state, our lieutenant governor is the COVID liaison because he's an emergency room physician,
Mm.
and his medical advice goes far with policymakers. And although it's been again, we've had numerous experts on the show that have been talking about long haul, that we've got a long COVID, that we've got to prepare for that. A couple of questions. I know you mentioned, you touched on it, but long haul, are we seeing it in kids as well? And how prevalent is it with patients that have been vaccinated or boosted, or is it more happening more to unvaccinated? I know Angela, who was on our show last week, she's the one with the brain issues. She
Yeah.
said the doctor told her that her brain was it was close to dementia brain. That's how
Yeah.
bad her situation was. But this happened early on. There were no vaccines available, so obviously she wasn't vaccinated. But where are we with kids and those that are boosted and those that are? Is it more prevalent in unvaccinated people?
Okay. So definitely we see. I mean, with regards to vaccination status, initially we didn't know when long COVID first came out. I remember in New York, they were organizing special clinics for long COVID where they had different doctors from different specialty coming in and then having a coordinated, standardized care plan for long COVID. But I think in terms of vaccination status, we didn't know what was going to happen. Um, we didn't know what was going to happen. So, but there is a latest study that comes out of Israel which talks about the effect of vaccination. If you're a vaccinated individual and you do end up getting COVID, your chances of getting long COVID decreases significantly. So vaccinations do help with that. I mean, people have a really hard time understanding what the importance of vaccine because it's just a shot, right? Um, but it's incredibly important because the only factor that determines whether you're going to have a mild disease or a severe form of the disease is your early and robust antibody response, right? And also along with your cellular response, and both of them are significantly increased when you have vaccination. So when you have a vaccine, when you're an adult and you've had your 2 doses of vaccination during the Delta period, you were able to mount an early and a robust antibody response, which helped you fight off severe infection. And not just that, now data shows that it decreases your chances of getting long COVID because that early and robust system limits the viral damage to your body. So with regards to kids, I mean, we will talk more about that later, but I'm just gonna talk quickly about kids. We currently do not have much data on and children below the age of 5 on the effect of vaccination because there is no vaccination for them. But we do see kids are affected by long COVID. The symptoms might differ, but there is a basis for a similar pathology in children. We do see some pediatric cases of long COVID, of kids who develop long COVID after significant who develop long COVID after an infection. But currently, I don't want to indulge in the realm of speculation, but I do believe that it's important to vaccinate kids against COVID-19, not just because, and this is a very common misconception and misinformation that because kids do are they do have less of a propensity to develop severe disease just because of the fact that older people have more ACE receptors than younger kids. You do see that a lot of kids. A lot of kids have less severe disease. It doesn't mean that none of them will. And also, the current pediatric death case, if you look at them, 1/3 of all pediatric deaths, if you look at their case history, they did not have significant comorbidity. So it's not that, oh, my kid has a comorbidity, so I'm going to vaccinate him. It's vaccination remains the best shot against even long COVID, long-term symptoms, severe disease, and hospitalization and death. I mean, even though we don't have much data on kids, right, pediatric cases right now, I would still strongly suggest that all kids who are eligible to get a vaccination should get a vaccination. Um, yeah.
Well, one thing we know here in the United States is that at the peak of Omicron, or as it was getting to the peak, pediatric hospitalizations was out of control. It was, in fact, at one point had surpassed the adult hospitalizations in some other areas on the mainland, not here in Hawaii, but yeah, it's incredible, and I don't understand why people choose to ignore that fact. But I am really intrigued by your concepts, I guess, regarding the long COVID, because it's almost like a pandemic within a pandemic, right? Because we got to deal with COVID. I mean, we still got to deal with Delta and Omicron and what's to come. But there's a whole new pandemic developing within the pandemic called long COVID, because that comes with a whole new set of consequences. As you just explained, we don't even know. Everybody's different. Every condition is different. Every symptom is different. It's not narrowed to one organ or one body part. It could be anywhere, and it all depends. And again, it's going to take years for, I think, for us to understand long COVID, but
Yeah.
we're not. It doesn't seem like we're prepared for it. And I think that the political consensus is we'll just take it day by day. We'll deal with it. And that's the message I get anyway. I don't know if it's different in Australia, but
Yeah, it's the same.
wow.
Yeah, I mean it does, but you do look at the future. I mean, they are working on that nasal, vaccine. I don't know if you've heard of it, but there was a study that was recently published where they talk about it. It did show like robust response against severe disease. I mean, it is the good thing about it is that it's a adenovirus vector-based vaccine. So I hope a lot of people who are misinformed by mRNA or don't want to put things inside their bodies. I mean, it's a common misinformation here. I hope this will make a significant difference. I don't think it will, but it might help because it's still in animal studies, so we don't know. But I think there is a three-layered response in this nasal vaccine. They had a systemic and a local antibody response, and also they had memory T cell response on the nasal epithelium, and also an innate mucosal trained innate response. And all that was a surprise for me. I would have never guessed, but that's in the works. So maybe as a booster shot, people who are afraid of taking an injection, it might help. I mean, anything.
That would be me.
Yeah, I mean,
That's why
really.
I thought I went with the Johnson and Johnson because it was only one.
Yeah.
And then I got boosted with the Moderna, so I
No,
feel
yeah.
good.
Yeah. I mean, even with the people who have been previously infected, there is a case that they should get the vaccine. So there is no reason not to get a vaccine or a booster shot. I know in terms of immunocompromised patient, they're considering a fourth dose. I know there was a recent study, and it just came out today. The fourth dose that was given to immunocompromised patient, there was because usually with the booster shot we had a B cell expansion. Excuse me, we had a T cell response, which is cellular immunity, and an increasing neutralizing antibodies. But with the fourth booster shot, I think given to normal patients in Israel, showed that there was no significant changes in the T cell response or your B cell expansion. There was just a increase in your neutralizing antibodies. So that was just one part of our immune system that it helped. So that's also educational because we're counting on it, right? And the last one was that the Omicron specific vaccine that Pfizer said they will develop. Well, in animal studies, it shows that it's not much different from the booster shot that we got. So there was not significant B cell expansion that was different from if you had just gotten the vaccine that was developed for the wild variant, the WA 2020. So WA1/2020, I mean, the same sort of response we got from the Omicron specific vaccine. So we have the best weapon available to us to keep the pandemic under check, is to get boosted and make sure that we continue to practice mitigation protocol, which is DVT, distance, ventilation, time, and plus masks. So that's when we give ourselves the best kind of protection when we're following all of it. Not just you wear a mask, but you're not. I see some people not wearing the masks on their noses. That's where the highest viral load takes place, and it's when you're most infectious. It absolutely makes no sense to me. But you make sure they're snug on your nose and your mouth over your. So that's the strategy that's going to get us out of here, right? Like I hope that even though the governments are not mandating it, the citizens would continue to take those measures to decrease transmission. But that could really help with the positivity rate in the beautiful islands. So
Well, we got to remember that we all responsible for our own actions, like you said, regardless what the government does. I know people would complain. You go to Waikiki, all the tourists they come from states that didn't have mask mandates, and they're all now wearing masks, and people would get very upset. I say, just don't go near them. You wear your mask. If you see someone without a mask, even if it's someone that a friend or a coworker, don't go near them. You stay away. Don't
yeah,
let that snot get in you, and you're in your mask. You'll be all right. I mean, it's frustrating. Last question, Doc. We'll wrap up with this. I appreciate you. It's 8 o'clock, and I respect your
yeah,
time. But going forward, we have Dr. Tim Brown, who's with the East West Center here. One of our most brilliant experts here. Been following COVID since the beginning. Was on the news the other day, and he said that there'll be one, possibly two more variants in the near future. It, and he also says you cannot predict what happens next. But what are your thoughts as it relates to another surge now that Omicron seems to have kind of quieted down? How long before uh, the next
yeah.
variant that will be a variant of concern?
All right, great question. So, basically, going back to the virology of things, right? Like when we look at the coronavirus, the virus itself, the protein that interacts with our body, it's a spike protein, and it contains two parts: the receptor binding domain and your, N-terminal domain. So there are multiple mutations that the coronavirus undergoes. Like we talked about, the variants, it can either give it a transmission advantage or immune evasiveness. Now the NTD side, that's a super antigenic side. A lot of mutation there help the virus evade immune system better, and the receptor binding domain has to be very careful because all of these mutations, they're selected for the best because a lot of viruses don't make it, and these mutations are very sensitive, and because of allosteric interaction between these mutations. So I mean, we saw early on with the Delta and the Beta and the Alpha, different mutation conferred different advantage. But what we see with Omicron is that there are significant antigenic variants, and also there are some advantages that it attains in terms of even functional advantages, not just transmission advantage that it gets. And we see that this happening in real time, and that's Australia, they have a genomic tracking system now, but that's where the genomics start. Definitely there's going to be more variants, there's no doubt about it. The mutations are somewhere between influenza and HIV. That's how fast it's mutating. We can see that I can definitely see another variant coming, and in fact, when we're talking about this, we were talking about HIV earlier in another meeting, and I was talking about how there is in Africa and in America, different variants were selected because in America they had a standardized care plan that really helped the determinants of health. Here in the U.S., there in the U.S., where they had the type of HIV virus. I think it's type B, which favored a less amount of viral load, less amount of transmission, because transmission was basically stopped because of the effective antiviral treatment that was given out in the United States, as opposed to in the parts of Africa where another type of variant, which was more highly transmissible, was selected just because of human intervention. And so this just goes out to show that this is a very evolving and dynamic scenario where we will not be able to predict what kind of selection pressures are on these viruses, and what kind of mutations will give it the best advantage. Usually, transmission advantage gives a virus the ability to dominate, the whole thing. And immune evasiveness also helps it. I mean, we see that effectively with Omicron. We see actual numbers dropping with Omicron. So just with the number of mutations that happen, there's definitely going to be another variant, but to what extent if it'll be severe. I mean, we recently heard about Deltacron, or like, it sounds like Star Wars characters, right? But we are hearing about all of these variants. There's definitely going to be more, but we would never be able to predict if it's going to be more severe or more immune evasive. It's a very dynamic topic, and I know a lot of virologists around the world and genomics scientists are working on it right now, but it's almost going to be impossible to predict. But will there be another variant? If that's the question, of course there's going to be another variant. What I see is that I see COVID booster shots, or like COVID vaccine shots, becoming annual flu plus COVID thing. I mean, this is not based in data, but that's what from my clinical experience, I would think that there's going to be an annual flu come COVID shot, because that's I mean, there's going to be a new normal after we get out of the pandemic, and we're going to have to right now we can only predict what's going to be, but are there going to be variants? Yes.
Yeah, I think and it was Dr. Tim Brown as well that said while Omicron was milder, well, he said while it was less severe, this by no means is a mild disease. And I think for the reasons that you explained tonight, more so the long COVID, I think people got to really start paying attention to long COVID. And as variants come up, I know, again, our lieutenant governor constantly says new variants tend to be less severe, but more transmissible. But think about this for 1 second. If you had a variant that was, let's say, 50% as severe as the last one, but the infectiousness was 5 or 6 times greater, the net impact is not a good one. You're getting more people in the hospital and more people dying than the more aggressive or more severe variant. And I think people got to understand that it's not so much, it's quantity over quality over quantity over quality. And I think we got to be very cognizant of that. Doc, appreciate your time. Not sure if you're gonna be joining us on the Clubhouse after this. Good. Guys, listen, right now, somebody post up the link to Clubhouse. We can continue to hear Doctor on our Clubhouse. Someone please put it up. Just click the link, guys. Download the app. It's free. You'll be taken right to our Clubhouse room, and you'll get to hear some more. Yeah, Dana, go ahead and put it up, and we'll get to spend more time with Dr. Grayson there. Appreciate you, Doc. I'm glad we connected. I do want to circle back with you maybe in a couple of weeks, a month, after we see some of these restrictions get lifted. And what I hope doesn't occur, I want to be cautiously optimistic, but I'm also a realist, and I don't like what I think will happen. So,
yeah.
Any closing thoughts? You're now a member of the village, by the way. You are a new member of the village.
Thank you.
Closing thoughts. Closing thoughts.
Yeah. Continue to wear your masks. Remember DVT, distance. Continue to socially distance. Make sure any closed area you go to have a proper ventilation, or be in nature's ventilation. Be outdoors, and decrease the amount of time where you could possibly be exposed to the virus. So that's DVT. Wear N95 masks, and if you can be boosted, if you're eligible to get the primary vaccine and be boosted, please do so. Thank you for having me.
Oh, thank you. Pleasure is all ours, Doc. We'll see you in a few minutes. To our viewers, thank you so much, you guys. You guys heard it from across the world. all the way from Australia. Thank you so much. For appreciate you sharing. Guys, we'll be, what is today? Today's Wednesday, right? We'll see you guys on Friday, 7 o'clock. Don't forget, join the clubhouse. We'll see you guys in a few minutes. Aloha. God bless. We love you guys. Take care.